So this is a tissue, segments of tissue that had been removed from lungs of a patient. So under low power, you can see that this area, you can see there's a lot of alveolar spaces. So all of this empty space here is actually an alveoli. All of these are alveoli. So if you look under high power, you can see that this alveoli is actually lined by simple squamous epithelium. So I'm on 40 times magnifications. You can see each of these spaces is actually alveolus. Okay. Right, here's is spaces of alveoli. It look a little bit congested with a lot of red blood cells within the blood vessels of the surrounding tissue of the alveoli. So if you go around, take a view of all of these vessels, or all of this tissue, you can see there's some inflammations here and there. There's a lot of inflammation going on in this tissue. For example, in this area, you don't see a very clear alveoli or alveolar spaces here. So if you go higher power, you can see there's a lot of inflammation going on here. Particularly, is predominantly is lymphocytes, and the surrounding vessel is also congested. Again, when you go in the low power, there's some changes here. You can see this is one of the lesions, this is another lesions, and up here is another lesions. I will go into that in a few moments. Before we go into that details, we go into this area here. You can see empty spaces here. It is actually a small blood vessels there, so don't mistaken this with alveolar spaces or bronchioles. So you take a look at it, and look at the higher magnifications of the vessels. You can see there's it made up of a smooth muscle layer there, with the inner lumen there. Within the lumens is the red blood cells. And you can see the wall is made up of mainly the smooth muscle layer, or what we call it tunica media. So this is just a one large artery. So back to the lesions. So we go to this lesion first, under low power. So this is actually a caseating or necrotizing granuloma. So you can see the center there. The center of the lesion is just a pinkish granular materials, and it's surrounded by rims of cells, and outside of these rims of cells is the lymphocytes and also plasma cells, which indicates chronic inflammations. So as we go into high magnifications, so how does the necrosis look like? It looks like this. It's just a granular acellular material. So this is under 40 times magnification. You can't see any cells, no nucleus, no cytoplasm to differentiate that it is a cells. So as you go towards the periphery of the lesion, you can see there's a changes there. There's there's a epithelioid kind of cells which has slipper shapes or oval shapes nuclei. And just adjacent to it, you can see a few multinucleated giant cells. And actually, these multinucleated giant cells and also the epithelioid cells is actually an activated macrophages. So they act as a medium or a protective against usual organism, for example in Mycobacterium tuberculosis. So they present a lot, they eat this Mycobacterium tuberculosis and try to kill them. And just outside the surrounding these multinucleated giant cells and also epithelioid cells is actually a reams of lymphocytes and so plasma cells, and these are again chronic inflammatory cells which will produce a lot of interleukin antibodies and prostaglandins that acts and try to kill all of the mycobacterium. So this is how a caseating or necrotizing granuloma in tuberculosis infection, Mycobacterium tuberculosis infections looks like. This is another lesions of it. You can see and you can see there's again a similar features, but this one also contain necrotic center surrounding by some epithelioid cells which has elongated large oval to spindle or sometimes epithelioid kind of cells, which is a macrophages, and it is surrounded by this inflammatory cell or the plasma cells and so lymphocytes, which is the chronic inflammations there. So this is how necrotizing granuloma looks like. And you might be wondering, what is this black pigments, granular pigment here? This is actually a tar deposit. So tar deposit does not indicate or does not present only in the smokers, but in people who live in a heavily or moderately polluted atmosphere or air, they will also have or has this kind of pigmentation or tar pigmentations. So again, just for a recap, the most important point to say that it is a necrotizing granuloma is: number one, it has a necrotic center. Number two, the necrotic center is surrounded by epithelioid cells and sometimes multinucleated giant cells, and outermost of these multinucleated and also epithelioid cells, they are also surrounded by rims of chronic inflammatory cells, which is the lymphocytes and also the plasma cells. So this is a biopsy from an unfortunate gentleman presented with productive cough and occasionally hemoptysis. And he is a chronic smoker who smokes around 60 sticks of cigarettes per day for the past 20 years. So this is a biopsy from the bronchus, or from his bronchus, and you can see under these low magnifications there's multiple fragments of tissue, but these fragments of tissue is mainly necrotic tissues. All of these mainly are necrotic tissue. but there are still some viable tissue you can see within it, but majority of it are necrotic tissues. Okay, how does necrotic looks like? So again, just for a recap, so you won't see any nucleus. So nucleus should be bluish in color, but there are no I would say nucleus presence in this cell, because all the nucleus had already necrotic and it's become reddish. If you see at this area, there are still some cellular outline, or sometimes we call it ghost cells, because it is already necrotic or dead, but it still has the architecture of the cells within it. But we cannot determine what kind of cells this is, because it already been necrotic, so there's no proper features or any features that indicates that this is any type of cells. But don't worry, we still have some viable cells. So if you see there's a lot of necrosis, you can say that it is either a chronic inflammation, a very severe chronic inflammation, for example in tuberculosis, or it could be a malignancy. So in this case, we take a look at the viable cells first. So these are the only few viable cells that we can see. It shows under low power. If you recap back your histology, it does resemble like a skin, right? Like a stratified squamous epithelium cells, and it does look like that because it is the similar cells, but in this case it's malignant cells. Okay, so you can see that this is the malignant cell. It displays highly pleomorphic kind of features. There's a variability in size and shapes of the nucleus, with mitosis. You can see also mitosis in this field. You can see I think 3 mitosis is present here, and most of the cells shows moderately pleomorphic. It has moderately nuclei pleomorphism. So, and some of the nucleus is enlarged. As you know, the lining of the bronchus is usually respiratory type epithelium, or pseudostratified columnar epithelium with cilia, and in a patient with who is a chronic smoker, or who live in a very polluted environment, air environment, they can present with some squamous metaplasia. So, and then it will proceed with squamous dysplasia, which is pre-neoplastic lesions, and then from that it will then eventually, if it's not the carcinogens is not ceased, it will transform into the squamous cell carcinoma. And if you see, there's some in between the cells, there are intercellular bridges. For example, in these cells, so you concentrate between two cells. Between the cells, there are some protrusions coming out from the cytoplasm of one cells, and it extends into the cytoplasm of another cell. So this is how intercellular bridges looks like. So in this field, you can see one intercellular bridges. Not one, it's actually these areas. If you concentrate in between the clear space in between the cells, there are intercellular bridges. And apart from that, if you see the surrounding stroma, it appears to be desmoplastic. So desmoplastic means there's an increase in the presence of the fibroblasts and also fibrocytes, or increase the fibrosis surrounding these cells. So this is how fibrosis or fibroma looks like. Desmoplastic stroma looks like. And apart from that, if you see, there's a few single cells that have a similar features as the main tumor in the cluster. For example, like these cells. So it is at the center here. You can see these few cells appear to be singly. So this is actually a squamous cells, squamous cell carcinoma that originates from the larger groups of cells here. So when you see a single cell, a single squamous cells carcinoma appear in the stroma, so this indicates that this is malignant. So there's presence of single cell in the stroma indicates that it's already metastasized, already invades the surrounding area. So this is the features that you need to see to say that this is squamous cell carcinoma. If you don't see this, then it will be just a simple squamous dysplasia, which is a pre-neoplastic syndrome conditions, which is just 1 or 2 steps further to develop squamous cell carcinoma. So also in this area you can see similar features as in the previous areas. You can see also some intercellular bridges in these fragments is more prominent instead of previously. You see just at the center there's a very big or very prominent intercellular bridges. And apart from that, what you need to see is the keratinizations to say that this is a squamous cell carcinoma. But bear in mind, squamous cell carcinoma can be divided into few subtypes, but predominantly it can present as well differentiated, where you can see prominent intercellular bridges and also some keratinizations. But in cases of a poorly differentiated squamous cell carcinoma, or sometimes we call it as non-keratinizing squamous cell carcinoma, you won't see any keratinization or intercellular bridges. So this is what makes your life a little bit difficult to diagnose a squamous cell carcinoma. But fortunately, in this case, there are still some individual or some keratinization expressed by these cells. So for example, in this case, you can see this pink amorphous no acellular materials. At the center of the screen is actually the keratinizations. So this is how a keratinization looks like. So if you're looking for keratinization, you should look a clear keratin like this one. But sometimes they do form keratin pearls. So we call it keratin pearls because it resembles a cross section of a pearl. So if you cut a pearl, then you can see there's a lamellated kind of features. So that's how a keratin pulse looks like. And this is another type of keratinization, or what we call it individual cell keratinizations, with the surrounding cell showing intercellular bridges. This is very classical of well differentiated, or sometimes we call it keratinizing squamous cell carcinoma. This is a biopsy taken from a 40-year-old lady who presented with a history of hemoptysis. She is not a smoker. Her husband is not a smoker. But unfortunately, chest X-ray shows there's some lesions at the left apical regions of her lung. So the chest team, or the thoracic team, did a biopsy for this unfortunate lady, and this is the biopsy. So you can see under low power there's a core of tissue here. Okay, what strikes you the most, what's striking with this core of tissue, is you can't see any alveolus within this tissue. It all made up of some atypical type of cells that are in groups, and you can see some carbon pigments here and there, but majority of the cells is not a normal lung tissue. So you need to go further, higher magnification, to view this tissue. So under 10 times magnifications, you can see that these tissues, or these cells, they are very atypical cells. They are arranged in a cluster, in sheets, and also clusters cells. They have moderately pleomorphic nuclei. So moderately pleomorphic means there's a variability in size and also shapes of the cells, and also there will be some differentiation in the chromatin, and how is expressed the chromatin is because in some nucleus you can see it's very hyperchromatic nucleus, it has a very hyperchromatic nucleus, and in other has an open or vesicular type of nuclei, where you can see there's a prominent nucleoli within the nucleus. So these are the atypical cells that made up this cluster of cells. So we go at low power to look any differentiations that can be seen in this tumor or lesions. So if you play around, you can see that this tumor forms what you say as a glands-like features, like hair. So what you should see in a glans is the presence of central lumens. So in these fields, you can see at the center there's an empty elongated shapes of structure. So that are the lumens of the that is the lumens. So surrounding these lumens is this atypical cell. So these cells forms a tubules, or sometimes we call it glands. So it's a gland forming tumor. So that is our first clue to see the differentiation of this tumor. So as we go around, you can see that this tumor actually has the tumor, the lesions have a very vesicular nuclei, and sometimes in some instances you can see there's vacuolations in the nuclei and in the cytoplasms. So there's a vesicular cytoplasm or vacuolated cytoplasm. How do you say that it is a vacuolated cytoplasm? Is vacuoles will be empty spaces that are currently filled with nothing because of tissue processing, but actually there's some there could be any kind of secretion within it. So in these fields at center there, you can see there's a one hyperchromatic nuclei, and the surrounding cytoplasm is vacuolated or bubbly looking features. So this is how vacuolated cytoplasm looks like. So most probably this type of cells do produce some secretion. So as we go around, we try to differentiate. So currently what the point that we have up to this screening, number one is these tumor cells of these lesions, or actually these tumor cells forms a gland-like structure. Number two, it has a vacuolated cytoplasms, so it indicates that it's more of a gland-like tumor. And number three, it has a very pleomorphic, not very, it has mildly pleomorphic mild pleomorphism of the nucleus. So, and in this area again, at the center of the fields, there's another structure this tumor is trying to form a gland. So it started to clear up the space at the center there to make way for the lumens. So it is a gland-like structure. So we go until the end. So remember, not just in exam but in real life, if you need to screen for any kind of slides, do screen it properly, and if you screen all the tissue that are present. So again, this is another lumens, another glands-like structure. The center here, bear with me. Yep, this is another tubules or glandular-like structure. So it has a lumen at the center there with surrounding atypical cells or pleomorphic cells. Here you can see the pleomorphism is a little bit marked. So there's a highly pleomorphic kind of nuclear features. The nucleus is start to be a little bit bigger with more less hyperchromatic kind of chromatin. So at the center here you can see one mitosis. Bear with me. Okay, here at the center here you can see one nice mitosis. So this is how mitosis look like in HPE or histological examinations. Here is another mitosis. Yep, another mitosis there. And you still need to go around a few more fields just to, you need to screen a few more fields. Here's another some atypical mitosis here at the center, and also at the around 12 to 1 o'clock there is another mitosis, but at the center here is a very atypical kind of a mitosis. Here is another atypical mitosis, you can see at the center here. Okay, this is under 40 but it's not that clear, but you get the idea. So this is another area that's showing the more of the vacuolated kind of cytoplasms. Okay, so at this point we already know that this tumor and this lesion is pleomorphic. Number 2, it forms glands. Number 3, it has vacuolated cytoplasms. And number 4, it shows pleomorphisms and also mitosis, like in this area. So basically this is already adenocarcinoma. So but bear with me, we're not settled with this case yet, because if there is an adenocarcinoma of the lung, we need to differentiate it. So we need to exclude either it is a primary arising, means it means arising from the lungs, or does it arises from other organs, for example in metastasis, for example in a colon carcinoma. So we did some stains. We need help of immunohistochemical staining to differentiate which are the primary sites. So this, number 1, what we should or usually do is the CK7 or cytokeratin 7. You can see there's a clear positivity in it's a strong positivity in almost all of the cells. So what you can see is there's brownish colorations in that appear in the cytoplasm and also the cell membrane. So this is how a CK7 or immunohistochemical staining looks like. So this is CK7, which is positive. Next, we also do CK20. CK20 is to, I will explain to you later regarding this immunostim. Bear with me. Okay, here are the tumor cells, because okay, this is CK20, cytokeratin 20. So if you look on the higher power, higher magnifications, yep, these are the malignant cells, and all of it are negative. Blue means no brownish colorations of the cytoplasm and also nucleus. So this is negative for CK20. And next, we also do differentiation stain there, or the stain that are very, it will tell us directly either it is from the lungs or not. What we do is the TTF1, or the name is thyroid transcriptase factor 1, where it indicates the most common tumor that express it is the thyroid, the lungs, and the liver. But in this case, because it is an adenocarcinoma, and it expresses TTF1 and is located in the lungs, and the TTF1 is also positive, so almost 100% that it indicates that this is a adenocarcinoma of the lungs. So this is how a TTF1 looks like in immunohistochemical staining. So you can see it will stain the nucleus with a brownish color. So all of these are the positive stain for TTF1. So just for our conclusions, so adenocarcinoma, it should has form or tubular or glandular differentiations. Number 2, or if there is no glandular formation or glandular differentiations, you should see mucin or some evidence of secretion, or cell that producing something. For example, in this case, we can see there's a vacuolation of the cytoplasm. So that if there is a vacuole within the cytoplasms, what you should think of is this tumor cell or these lesions produce cells, or produce secretion. So if cell produce secretion, so it is belong to the glandular type of cells, and most probably it is a adenocarcinoma. And remember, if it is adenocarcinoma in the lung, you need to differentiate either it is a primary or secondary. So for the primary adenocarcinoma, the stain that you need to see and be positive is the CK7 and also TTF1, and CK20 should be negative. And just to tickle your mind, to tickle your brain, you can have a look in a Susan Lester Manual of Surgical Pathology. You can have a look in that book what are type of tumor that has a CK7 that are particularly determined by the positivity and the negativity of CK7 and also CK20. So that it just nice to know. You can have a look and study it a little bit. By that, I hope this session will help you to understand more regarding this adenocarcinoma.